So today we are basically discussing the thing. Actually, it is very short notice, so we don't have a actual PowerPoint presentation for the actual topic. Okay. So it was a basically we can tell interactive session how to start a MICS program in this perspective in West Bengal in the government institution or in the private institution. So I am doing MICS for last around we have started around 2014. Okay. Now for around 2012 years we are doing the MICS. And for me it was a journey from an institution, government institution to different private institution. Ultimately one private institution we have been there for last 5 years and doing the basically improving the program. So whatever the thing, whatever the program you are starting, first of all, you have to know what are the pitfalls, what are the complications, and what is needed. Important thing is that. So it may require resource. That resource maybe require human resource, maybe the funds, everything. And one is the skill. Skill. What is your fundamental skill is the post MCS training of the either normal surgeries, those open sternotomy. That is the conventional method of doing the surgeries. Now we are doing more or less, still we are doing more than 20% patient in sternotomy. So it is the normal skill. What about the upliftment of the skill? The upliftment of the skill depends on how you are comfortable coming out of your conventional zone or comfort zone. So that basically the CBG and MICS CBG started around 2006. You know, the back-in principle, though that was that time called the meat cap. So it is not a very old process. It is a new thing. And it has progressed after that. It has progressed after that. In some institution, in some sense, by some human excellence, by the team excellence, both. In sporadic institution, it gone by the human excellence. In some institution like Leipzig, like Belgium, like the Singapore Institute, so they are going by the team excellence. They are progressing further. Here, still in India, it is the human excellence rather than the team excellence. You don't have a very good MICS institute only to have a fellowship and go there, acquire the skill and come and go. So it was for us, for me also, it was the quest for further skill upliftment. So that skill upliftment in the form of MICS, main thing, it is a small incision. What are the advantages? Maybe small incision, and it requires many advantages are previously told that blood equation, blood requirement would be less, the discharge would be less. But with the advent of technology and very frankly speaking, with the sternotomy also, the blood requirement, the length of stay had significantly decreased. Pain. Regarding the pain, post-sternotomy pain, it may be lesser than the post-anterolateral thoracotomy pain. So these all, as a professional, we all know. So what is the important? Important is patient wants to have a smaller incision. That is the near cell. Because they have the alternative. You all know we can go for, there are now complex PTCS are there, complex any ETO, CTO arteries they are opening through lots of gadgets basically. The result may not be very lasting, but still at least they can start. They can give them option, okay, there is no surgery is required, the opening of bones are not required, opening of sternum is not required. So we have to give them alternative. For the general surgery, they have gone to the laparoscopy. For other surgery, gynae, urology have gone. But the cardiac point of view, because of the less margin of error, we are a very hesitant lot. As simple as that. To go beyond our comfort zone. Because, not because of our lack of skill, because we are afraid that small margin of error can take the life of the patient. So it is all in the head, nothing more than that. So what is important? What is important is you have to ensure at least for opening of your cases in MICS, the mortality or complication doesn't occur. Try to avoid it. We can also try to avoid it. So it is better planning, better acquisition of the skill, better placement of the your anesthetist, your perfusionist, everyone, and third is choice of the patient. So when we have started with the ASD, as simple as that. Okay. Regarding the anesthesia, only anesthesia, two things are most important. They are doing many things, but two things, as my point of view, was most important. One point is your anesthetist should be well versed with a single lung ventilation. For the CABG is must. For the CABG, it can partial things can happen, the upper lobe collapse, some, but for the CABG, major part, and 99% of patient you will require a single lung ventilation. For the valve patient, ASD, don't need single lung ventilation. You can go for a double lung. After bypass, you can stop the ventilation, doesn't require a ventilation. Okay. In CVG also, if you are planning, okay, that patient is adamant, I have to go for MICS, the heart is bad, you are already planned for a peripheral bypass, then no need for single lung. But important is that one lung should be ventilated during that bypass. Otherwise, the partial bypass would be achieved because the left ventricle is not vented. So there would be a gap of saturation, it will decrease in the upper limb or something. There will be a problem during the saturation. So it is better to also ventilate the single lung during the your peripheral bypass in CVG also. So for anesthetist part, one part is important. Your anesthetist should be well versed with single lung ventilation. That previously it was only by double ventricular tube. Now it is now better managed by the endobronchial blocker. We are using that now. Endobronchial blocker, selective blocking of that airway. It is more comfortable for the patient also. You don't need to have the change the tube after the operation. So it is better to go for it. It is okay. Double endotracheal tube is also not bad. Can do it. Next is important, not must, but should have a TE. Should have a TE. During our starting time, there was TE or not there. It was only by finger palpation and everything. The guide word is not in the RA or not. We have to finger palpate through the incision. But now through the TE guidance, you can see the where is there or not. How is the heart holding during your op pump bypass and everything. So TE more or less during valve also after putting the de-airing part by TE is very soothing. You are not blinding by what air is not or not there. So for the anesthetist part, one anesthetist who is willing to do MICS because of time period would be more. He wants to be in your side during the complication. That is the mentality. And second is two things. That is one of thing is the T. Second is single lung ventilation. Many persons, many anesthetists are doing the IJB line during the bypass patients, ASD or something. They can or might not, we can do it inside also. So it is not must. But two things anesthetist should have. Second, coming to the that is the most important part. You should know about what is going on. Some papers are there, now the YouTube videos are there. Okay. And you can always go for a fellowship or a smaller fellowship or observership, not a fellowship actually. It is an observership to a center who are mostly doing minimal. For me, I have gone to the your method. Dr. Chirag Joshi was there. He was doing the surgeries during, and go to a center which is not so sophisticated. That was important part is not written in this paper also. If you are going for a basically four grades of analysis are there, know the grades. One is direct vision. That is the level one.
ये क्या है
Level one is
कहाँ से मिला ये
around
मिला ये वाला दवा
6 to 7 centimeter incision, direct vision,
दाम कितना है इसका
and the all
एक्स्ट्रा
surgeon will do it. No telescopic vision. Grade two, more or less
ऑनलाइन
there is
दवा
procedural incision and some telescopic vision or the
ऑनलाइन में अच्छा मिलेगा
camera vision
और
will be
वहाँ
your
पहुँचाता
head.
होगा तो
Third and fourth. Third, fourth is endoscopic. Small incision 1 to 2 centimeter to 3 centimeters and totally
डबल लाना
endoscopic.
होता है जो भी हम
Robotic assistant being the third. Fourth is totally robotic. Totally robotic means total take up without any incision.
15 दिन का हो गया तुम्हारा 1 2 3 4 बताओ
Okay. So many centers
क्या
are
वाला जो है
all
ना
beyond our age.
ऑनलाइन जो
That
आता है
is like G and other persons in Singapore also. They are doing the total take up now. Total telescopic means the robots are there. The whole operation is ultimately going through the robots, and more or less 90% patients, 99% patients are going for that. So you are seeing that and coming back. Now here we are not seeing robots. We have no robotic exposures. So it is very difficult to immediately start your program without that level 3 or level 4 backup. So go for a center what is more or less doing the grade level 1 and level 2 work. That is the starting point for you. That you have to see. And important thing is that Dr. Joshi, what we have seen there, he is very much comfortable with doing the things. Seeing him would not, you would not like that. It is a Herculean task. You have to do this, you have to do that. He is doing is very comfortable. So go for a center where they are accustomed or habituated to do it and see that master in work. Don't go for a person who is also now learning. So see the proper work, how they are doing, what procedure they are taking for doing the things, what the instruments. That is the important thing to ask. I asked Dr. Joshi for the instrument. He has also told me like that. He has started with a custom. So position of the CBG, it is basically around 15-20 degree off, only at the scapula. The whole thing, whole waist would be the same plane. Because of the, you can go for a cannulation during the waist, right? So there is a small thoracotomy. And this is the tissue retractor. This is a tissue retractor. It is the only sole job is the soft tissue is retracted from your site. So this is the retraction for the lemma. We have started the lemma retraction with a normal thoracotomy retractor with a heavy blade. That heavy blade we used to put the pressure here and keep it like this. Small around lean thin patient, lemma would be visualized with that. So for the lemma harvesting, very important is seeing the lemma from your anterior side and the posterior side. So keep your soft tissue full clear. During seeing that, you can see lemma very clearly from the MSS view. This is the pericardial retraction we are doing now. and this is the aortic exposure for proximal. So important is that suture that is opposite to the aorta pericardium, and it will close, put your aorta towards you. This is a signet ring clamp for the proximal. But if you are going for the fourth intercostal space or third, you can go for the fourth. Aorta is very close to you. You can do the normal clamping also. Doesn't need the signet clamp. They are going for the fifth. ফিফথে যা হচ্ছে বলে এখানে এত তোমার টানতে হচ্ছে. So coming to the CVG part. CVG part, whatever is the important is suitable patient selection. Whenever you are starting a program, your patient selection would be very strict. Don't go for a obese patient. Don't go for a COPD patient who cannot withstand a single lung ventilation. At least during the procedure with a single lung ventilation, your PO2 should be more than 60 and PCO2 should be less than 45. And saturation more or less in the skin should be more than 90. They can modify the other things like tidal volume, single tidal volume. They can increase the FiO2, but important is the CO2 and PO2 should be in this range during the OT. So very important, you start a patient with a very less COPD or no COPD at all. Okay, go for a patient who is more or less leaner or thinner. Regarding the heart, it is better to put at least 50-60% EF. Better to go for a single or double vessel disease first than the right side disease. It is only left side disease, you go first. Okay. Next is important, very good view of the peripheral vessels. If you are starting a program, you need to go for a peripheral bypass. Atherosclerotic femoral artery or iliac artery would give you a nightmare. During the cannulation, a problem in the cannulation or a catastrophic cannulation, we lose the patient. So important is at least go for a ultrasound Doppler if you are not going for the CT angio. At least go for a Doppler to see the iliac vessels, see the femoral arteries, it is cannulable or not cannulable. Okay. Next is important, your instruments and single lung, whatever the thing is, you always know. And other things you have to know, it is not a reduced surgery. You are not going for a reduced surgery through a small incision. You are not going for a very much kyphoscoliotic patient, or dextrocardia patient like this. This is absolute contraindication. You should not go. So other things are relative contraindication. For COPD patient, if you are adamant you are going for a MICS, you can go for a bypass, peripheral bypass, and go to MICS. Very for a personal perspective, I don't go for a bypass for a CVG. It is better to go for a op pump MICS than going for a pump. Very rarely the patient wants a MICS and a very bad heart, we electrically go for a pump. Otherwise, it's better to try to go for a op pump only. Next is hemodynamic instability or emergency. You have to go for a sternotomy. Don't go for peripheral bypass and everything. During doing the thing early, or you are going for a hasty peripheral bypass, the chances of complication will be more. So it is better to go for a sternotomy. So any hemodynamically unstable patient, emergency patient, you have to go for a sternotomy. This is absolute contraindication. During last OT, there was a patient, it was active pain was there. Patient was wanting MICS. During the starting, the incision, patient gone into VTVR. We have to go on sternotomy and done thing. There is no wait for that. You don't go for peripheral and everything. So whatever you are accustomed or more habituated, during emergency, go for that. So relative contraindication, that is I am telling you. That relative contraindication means you can go for a bypass, peripheral bypass, and overcome the contraindication. Simple as that. So low ejection fraction, significant left subclavian artery stenosis, you can go for a left, that is the vein part. Always go for a saphenous thing or something. Significant peripheral vascular disease, you have to go for a buoyant cannulation or axillary cannulation if required. If you want to go for that. And severe obesity, BMI, we have done 110 kg, 100 kg patients. It's difficult, but can be doable. Not like that. So other reduced surgeries, I already told you. Pulmonary disease, same. The use of cardiopulmonary bypass may be helpful to overcome few of these contraindications. So surgery procedure, again there is an incision, that is a curvilinear incision. What the incision part you want to do whenever going for a single vessel or a multi-vessel. If you are doing for a multi-vessel, the incision would be better to go for a lateral part. Okay, more towards anterior axillary line. If you are going for a single vessel, your incision would be more towards the mid axillary line. It is close to nipple. If you are going for a multi-vessel, go for a more lateral way, because the lateral part of the heart and inferior part of the heart is better exposed with that exposure. Whenever you just open the pericardium, the heart will be in front of you. And go for a single vessel like only LAD, you don't need that exposure. So it is better to go for a more mid axillary line. So incision corresponds to the mid clavicular line, placed on more lateral than medial. That is for the multi-vessel part. And the intercostal site of entry correspond to the cardiac apex. Again, this finger. One of the thing is go for the X-ray. See the X-ray where the apex is. If it is fourth intercostal space, you try for the fourth intercostal space first. Hook your finger. If your finger coming like this in the apex, man, the apex is below in your finger, your entry point is good. Okay. If your finger coming like this, your entry point should be above. You are going below. Okay. So Lima harvesting in a MICS through MICS vision, it beat lengthier first day. We have started with around 1.5 hours. Now we are coming down to more than half an hour around. Lima harvesting, important, very important part is that for a MICS CABG, Lima is the main thing. Very rarely you are going for a MICS and doing all by saphenous vein grafting, except the CKD patient where a fistula is there. So there is a chance of steal through the Lima. We have done that only for that CKD patients, but the fistula is there. The fistula is there during dialysis, the Lima will flow to the dialysis line. So there will be a selective steal. So that patient you should not put Lima. Otherwise, during MICS, it is better to go for a Lima, because it is surgically more accessible, surgically more doable. Lima LAD anastomosis is most easier part in the MICS part. And very important, if you are not going for the aorta, or aorta is too far, sometimes aorta is too far, you cannot access it. Despite your signaling everything, the aorta is too far towards the right. You cannot access the aorta for the proximal. What is important? That Lima will act as a proximal artery. Just put an anastomosis of vein or radial or Lima to the Lima and do the whole things. So your Lima harvesting, the MICS, you have to do in a very observant manner and very strictly without injury. That is the most important part. So Lima harvesting, upper part is easier than the lower part. Upper part you can see up to the subclavian. Lower part you have to do some maneuver or put your assistant do the open the just pick the dipisternum up. Then you can see the lower part up to the bifurcation. But it is always can be accessible from the minimal invasive view and the bifurcation up to the artery. So Rita harvesting during the MICS we have done through this incision only without robotic. Important is you have to open the right crura and see the vein first, clip the vein and remove the vein. Then the artery will be in front of you. But the length of Rita through MICS may not be sufficient to go to the PDA. So only for left side you can do the thing. But for the you are going for a PDA, you have to take a vein or the radial. No other option. Again, the come to the octopus. There is a mectronic made octopus is there for the endo part. There is a rod there. You put the rod here through a GP sternum, below GP sternum a incision, and the pod is like that, and it can be put in the pod. After the putting the rod, you can put the octopus pad there. Still, we are not using the normal octopus. Can be stick to that normal retractor or the MICS retractor. You can do the normal CVG. Basically, after lima harvesting, doing the proximal or doing the proximal lima and vein harvesting, so it is more or less normal CVG. Only thing you have to now actually I am doing from the right side only, not the left side. Left side is a bit problematic because seeing it is difficult. Right side view would be more better for you. And putting the LED would be most accessible part. You can do always see the LED. Ramas and OM would be in front of you if you are doing the incision a bit later. PDA can be seen very good with that same incision, but RCA not accessible. If you are going for the RCA, either go put the patient in pump, see the RA part and go, then you can do it. So, part of the pericardium, it is better to close over the lima without any tension, without putting any tension on the lima. So, lima LED anastomosis should be covered if it is possible without tension. If tension is there, just keep it. So, regarding the CABG part, you need the lima retractor. I have done it with a normal thoracic retractor, but it is a very cumbersome. For a surgeon to see upper part is very good, sometimes seen, but it is only possible for lean thin patients. For proper retractor is required for a more or less middle weight patient because the chest is heavy. Only for that single thoracic retractor cannot retract the chest without very much giving either fracturing the ribs or something. So lima retractor is a must for doing the CVG. Second is clip. Lima clip, long clip would be required. One long clip is that is the normal endovascular instruments like this outside shaft. Another long clip holder is available with Edwards. That is a normal clip but with a longer shaft. The normal clip, but shaft would be more longer. But there is a longer clip holder. We have started with that, but problem with that, you will obscure your vision. It is a thick instrument. So if you want to start, we can talk with the Edward and they will give that long instrument, long clip holder also. Before you come to the normal clip holder, that is with the shaft. And cutting scissors will require to cut the lima. That is normal scissor we can do for the time being, but later you can go for the shaft. And one retractor will be forceps will be required to hold the lima. That is the three things you require for the lima. And after lima harvesting, one is retractor, that is lima retractor, one is the clip holder, normal long handle blade. খুব ভালো করা যায়, কিছু অসুবিধা নেই। হ্যাঁ, হারমোনিকে ভালো হয়, সেটা নিয়ে অবভিয়াস আমাদের মানে আমি বলছি যদি হারমোনিক নাও থাকে উই ক্যান ডু ইট, এরকম নয় ব্যাপার নয়। যেটা নর্মাল আমরা যেভাবে লিমা তুলছি সেভাবেই তোলা যায়, সুন্দর দেখা যায়, দেখা নিয়ে কোনো প্রবলেম নেই। ইফ ইউর এক্সপোজার আর বাকি রিট্রাক্টর যদি ঠিক থাকে and you have to identify the lima where it is first, then put the retractor blade. One time I have injured the lima, it is very close to the incision, that I have now shifted back here. The incision previously we have done here and lima was very close, blade had injured the lima. So before putting the blade, now I have make it customary to see the lima first, then put the blade. Lima can be seen to either pulsation can be seen, or for a lean thin patient there will be very good visibility of lima through this area. After seeing the lima, we put the blade. And be habituated with lima vein, lima radial, lima rima anastomosis. Then one pain in the head is gone, that is the proximal. For the MICS part, proximal is a pain. If the aorta is very away, you have to keep the aorta. And second problem is any injury to the aorta, any problem, you have to open. There is no other option. So if your lima is good, now I am going more or less to that part. I am doing more or less lima radial, lima vein, and lima. And don't very rarely I am going for the aortic. One part is that you are not handling the aorta, chance of stroke is less. Second part is it is better in MICS. So and lima after MICS moving, it is more thicker and more pulsation is there. In the very good harvested lima is possible for a lima. You are doing the sternotomy, na? If you are doing MICS lima, it will be more broader. Injury to the lima and everything is less because the vision is more. So be habituated with that lima vein, lima radial, and lima rima. Then one headache is gone. You don't have to do a proximal anastomosis. And in fact, you have to go 2 or 3. That is very difficult. Because the lung, whatever we are getting the patients from cardiology, that is not a good version. EF is low, heart is dilated, more or less not more than 45-50%, 40% around. So that time your anesthetic management and everything, the RV may come in the way during your cost clamp, side biting clamp. So it is better to put a lima radial, lima vein, and lima is better than the putting a side biting clamp in the aorta. Another important is whenever you are young surgeons, you are starting a program, what important is your HOD. He is supportive or not. Like my HOD, his father, he supported me a lot during MICS. He always start MICS, start. So if you require a person who is already persisting you to go ahead, is always an easier job to do. Your own wishes should be there, but the other person should be there who can give you motivation.
Incision approach transaxillary.
ট্রান্সএক্সিলারি আমার তো আমি একদমই করি না, তুমি করো? ট্রান্সএক্সিলারি মেনলি এখন করে হচ্ছে বোধহয় করে অরুণাংশুদা করে, সন্দীপও বোধহয় ট্রান্সএক্সিলারি করে না, অরুণাংশুদাই মেনলি করে। ট্রান্সএক্সিলারি আমি কোনোদিন করি না। আমার তো ভিএসডি এএসডি যেগুলো হয় সবই আমি ভিএসডি রিসেন্টলি করেছি, আমরা এটা দিয়ে করেছি। সব থেকে সুবিধা হচ্ছে এটা দিয়ে করার, if the pericardium is open, SBC, RA, aorta, more or less in front of you. And if it is a small heart, then SBC, IBC junction is also in front of you. Doing a full taping the IBC is not a problem. For the axillary part, most probably Urangsu will be a better person. Axillary part I have never done it. Thinking but never done it. We are doing mainly bilateral. Now we are mainly VSD we have done. One top we have to see. We can do it or not do it. VSD is better, more or less can be seen. I've done that recently. It is always okay, approachable. But regarding the RVOT part, we can see or not from this part. And basically, we cannot open the pulmonary valve. Then I have done one patient in DCRV with VSD. That is, one incision was there, one incision was there. Open the pulmonary valve through this incision and VSD closed through this incision. But that is not an ideal. You have to do for a single incision. Double incision is not a good way to do it. We'll see, let's see. You can do it or not do it. Basic things, you can start with your or already having resources, you can start. Already you will have resources that you can start the thing. If you can start the thing, then it will go. It will become a habit. You will do it regularly, then it will become a habit. Everything would not be in front of you before starting. You start with smaller, like many instruments, like I can tell, can be made custom made. One or two instruments you can buy with very less cost. But the custom made part is very less cost. In fact, I have during starting in Dishan, I have bought a Lima retractor from the Delhi based person, and it is more or less better than the failings. Still it is having me, and there is a blade with that instrument part that was a Rima blade, and it is very much helpful during taking the Rima. That is not present with the failings part. He have invented that and keep it with that. That person number is with me. If you don't, that is a more or less the failings part cost around 12 lakhs, more than 12 lakhs. Lima retractor. This person takes around 4.5. So instrument is not a problem. If you start, instrument is not a problem. And for you, it is a bliss. Basically, started patients will be, everyone can be done na, here. We have in private, na, everyone cannot be done. But here, every patient, they are willing to do MSS. Now, one of the problem is patient selection. We don't have this problem. You have every type of patient. Sinus venosus ASD. Heavy, very much approachable. In front of you, in fact. When I open the thing, it is just in front of you. Sinus venosus ASD. In fact, in my private, in the Dishan, we have started the MSCS program with a sinus venosus ASD. And the HBC cannula, you can do through this small incision only. Just it is same incision, same cannulation. That is a, you can do a angle cannula, either metal or plastic. Just with a forceps hold it, put the incision and give the angle team inside, and it is in front of you. It is more easier than the normal HBC cannulation. So HBC cannulation you can do, IBC cannulation you can do the femoral. For the cardioplegia part, there is a long cardioplegia needle that is available everywhere. That is available. Long cardioplegia needle is most probably available with without vented. तुम्हें भेड़ नहीं लाभ नहीं. During the deaeration, you cannot see, you cannot do the deair.
Yes.
Exactly. So भेड़ নিয়ে তোমার খুব লাভ নেই এখানে. এখানে your perfusionist and anesthetist will do the deair. You cannot do the deair. Now we are doing some compression like this, but that is not adequate. Your anesthetist putting the lung and your perfusionist, that is the, and important is whenever just keep the head up and below twice thrice. So, and T guidance, that there is much air is not there, then you open the thing. So you cannot do DR by your own. And another important part is for valve patient, ASD patient, you have to, you want to put a pacing wire. You have to put the pacing wire at the arrested heart. Exactly. You have to put the pacing wire. That is a small things, but patient, you have to put the pacing wire in the arrested heart. Never in the full heart or during off bypass. Huh?
And the MICS,
Hmm.
Shaka, Dr. Sengupta, all make MICS. Just like the minister. This is a minimal incision career. Upper minister to me and all. When we started thoracotomy, yes. Right anterolateral thoracotomy, yes. Usually consecutive 2009. After that, minister saw me every year with ministrotomy, Dr. Sengupta used to do. It's not frequently, but
That is one of the important things.
one a month.
Mini stenotomy or anterolateral thoracotomy.
We bought a Chiku clamp with our
You are doing a patient who is adamant to do a MICS, but very small. Femoral cannulation is bit problematic. Some last time we have had, that is the weight was 30 kg. The femoral is very small. We cannot go for a femoral cannulation. That is one of the options. Go for a mini stenotomy.
What is doing? But the best part is if you can do endoscopically. I'm not talking about robotic. Endoscopically with minimal or direct vision with minimal retraction. It is the best. Cases is the cases requiring CTV is same invasive as open sternotomy with CTV.
Because CPV is part of the invasion. CPV is an invasion. So it is best for the CVG, MICS, op pump, total arterial. That is the golden. And if you can go with the robotic.
These two clean. So forget about at least to start with is the NDR.
Because these things will treat you regarding the femoral cannulation. Important is femoral cannulation.
Is better, especially in EDU cases. EDU cases, it is very easier to do NDR or ADR, not to the sun.
You don't peel off the pericardium, you go through the pericardium. You don't need to peel off the pericardium. No? You can see the LA, you can just see the RA. Except the cos clamp part, you don't need to peel off the pericardium. From the aorta. Only from the aorta, you need to peel off because you have to cos clamp. Otherwise, the thing is stuck. Okay, you open the whole chamber with the pericardium. No problem with that. You're closing with the pericardium. The pericardium is already stuck with, na? So it is a part of the.
You will have a the femoral. Robotic cannulation for femoral or your direct vision lobe. And you no need to dissect the RA.
Exactly.
In case of mitral. So deep incision anterior to the pen. It's anterior to the lung higher.
Many persons are doing that. Many persons are doing the tricuspid valve surgery with robotic assisted. That is the same. They're not opening not peeling of the pericardium. Just open the cavity over the pericardium and closing it above it. So it is the extra layer, more or less, nothing more than that. You are going for the inside. You are not going for the outside. Because you are already doing the femoral cannulation. No, you have no need for IVC exposure. And many persons they are with a vacuum assisted drainage, they are not doing the taping of IVC also.
Are you using carbon?
Carbon dioxide we are using during the dearing part. প্রথম থেকে শুরু করা হবে। Start with the carbon. না এটা ফর আমি ওপেনদের জন্য আমি কার্বন ডাইঅক্সাইড দেয়া থাকে আমাদের সিলিন্ডার থাকে ওপেন পার্টেও we have a cannula that is supplying carbon dioxide simultaneously in the field. Dearing part is important. কার্বন ডাইঅক্সাইড তোমাদের কি নেই এটা? হ্যাঁ, মানে একটা এ লাগবে তো শুধু।
Cylinder.
হ্যাঁ,
Carbon dioxide থেকে লাগবে না? Why you don't require DI?
why?
This is what you Carbon dioxide is heavier than air. So your cavity of the heart will be filled with carbon dioxide. And carbon dioxide will be absorbed within the blood.
It dissolves, no?
Which is really a
It
chance.
doesn't obstruct, it dissolves.
Whereas that air will be dissolved. Means that carbon dioxide.
Carbon dioxide will dissolve. It will not obstruct. Another problem is the MICS part in that is the lower lobe collapse. This part of the lung used to collapse. Very much good physiotherapy will be required afterwards.